Hope I'm audible and visible. So sorry for the delay today. So we'll start off with where we left yesterday. So I've already shared the PDF in the group. I hope it is there on the group. If you have missed it off, just check the WhatsApp group. I've already shared the PDF with you guys. So let's begin with today's lecture. So we stopped yesterday at the oral cavity and now we are going to continue the oral cavity. So what are the warning signs of any lesion being a malignancy in the oral cavity? So whenever you are going to encounter an ulcer which is more than 3 weeks old, or whenever there is going to be a pigmentation change. So if you remember the A, B, C, D, E, when we talked about the dermatological conditions, we talked about A, B, C, D, E, asymmetry, border, the color, then you can see the depth, and then also you can see, yes, you can see what is called as the erythema. So whenever these 5 features were there in a dermatological condition, we suspected a malignancy in the skin lesions. Similarly, in the oral cavity, if there is any pigmentation problems, if there is non-resolving inflammation or induration, so any lesion, so if you can see here, there is a lot of induration here, so it is a hard tissue nearby. So whenever you can see an induration near that lesion, or whenever you are going to have a trismus, so trismus is inability to open the mouth in an acute onset. So in an oral submucosal fibrosis, the patient is not going to be able to open the mouth because of the fibrosis. But whenever it is going to be the trismus, there is the problem in the retromolar region of the what you can say in the oral cavity, and that is the reason the patient is not able to open the mouth properly. If the loosening of the teeth start to happen, or if there is going to be altered dental occlusion, so sudden fall of teeth, so sudden 2 or 3 teeth start falling off without any reason, then suspect an oral malignancy. Or if there is any associated numbness. Sir, why numbness? Because you know that if sensory innervation is going to be affected, if sensory innervation is affected in that region, naturally there is going to be a numbness in that region. And if there is going to be associated cervical lymphadenopathy. So these are the lesions where you need to think about a malignancy and you need to suspect a biopsy. So let's repeat: persistent non-healing ulcer, pigmentation, non-resolving inflammation, trismus, loosening of the teeth, numbness, or cervical lymphadenopathy. So if any of the things are present, that is the time you are going to go for a biopsy. So if you can see here, you have to take the biopsy. Sir, biopsy kahan se lene ka? So always take the biopsy from the region which has the normal tissue as well. So you are going to take what is called as a wedge biopsy. Wedge biopsy is a type of incisional biopsy, because you are not going to take off whole the tumor or whole the chunk of the tissue. You are going to just take one part of it. So it is called as an excisional biopsy. So it is an incisional biopsy. And what is the type of incisional biopsy? It is called as a punch biopsy. So you are going to take biopsy of the lesion and you are going to send for histopathological examination. So biopsy is going to be diagnostic and confirmatory. Incisional biopsy is required deep and narrow tissue rather than getting it broad, and you have to take normal tissue along with it, never from the center, because center is going to be necrotic. Punch biopsy can also be taken for small lesions. So what type of biopsy? Incisional biopsy. Incisional biopsy is indicated, and along with incisional biopsy, make sure that you are going to take some amount of normal tissue as well. So whenever you are going to come across a patient of oral malignancy, you are going to go for it. Then you are going to go for a neck node if possible. If a neck node is going to be positive, you can try and do a neck node FNAC. So if neck node is positive, naturally the patient is going to require MRND. But sir, if FNAC is going to be negative, then I can actually plan for what is called as SLNB, sentinel lymph node biopsy on table. So how to go for this management, I am going to tell you in a short while when we are going to discuss about the management flowchart. CT scan is important. Sir, why CT scan is important? To look for bony cortical invasion, and thoracic staging. So to look for any metastasis and to look for bony cortical invasion. So it is gold standard for bony cortical invasion and lung metastasis or mediastinal nodes. Also you are going to get an idea about the operability. So is the tumor operable or not? You are going to get an idea based on the CT scan. USG neck is important for neck node assessment. You can take FNAC if it is going to be there. If FNAC is positive, then naturally the patient is going to require MRND. PET scan to look for distant metastasis, or we have already discussed that we might require it when we are going to talk about, yes, we are going to talk when we are thinking about unknown primary. So whenever you are thinking about a carcinoma of unknown primary, you can think about a PET scan. Dental OPG, so whenever the patient requires any dental reconstruction, then a dentist might require an OPG. And sentinel lymph node biopsy for occult metastasis in clinically C0 node. So whenever we already talked about SLNB, so SLNB can only be done if the disease is clinically N0. So if it is a FNAC or a clinically proven disease, so if nodes are palpable or if the FNAC is positive, there is no role of SLNB. So always remember that SLNB can only be done if it is going to be clinically node negative disease. So if it is a clinically node negative disease, then only SLNB has its own value. So always remember what are the surgical managements important. So for any oral malignancy, surgery and surgery is very much important. So it is the best management for oral cancer and it is superior to the definitive radiotherapy. So previously they thought that why to do such morbid procedure, why to actually go for a resection. We already saw that if the lymph nodes are going to be positive, then naturally the survival is going to reduce by 50%. So they thought why to actually go for a radical surgery, why not to give radiation. But all the trials which were done suggested that surgery is the curative option for the patient. So surgery then followed by radiotherapy. So radiotherapy सबको देने का क्या? So no, I am going to tell who the patients are going to be the candidates for radiotherapy and chemotherapy. Pre-operative planning is very much important. You remember that the oral cavity is in relation with the trachea and airway. So whenever there is going to be floor of mouth involvement, you need to plan the airway. So airway assessment and resection accordingly what is required. Then think about the neck. If neck is positive, go for MRND and then you can go for reconstruction. So what are the approaches? First, plan about the airway management. You should make sure that the patient's airway should be patent. If airway is only going to go, the patient is not going to live. So airway is important. What access are you going to go for surgery? So if it is a small tumor inside the oral cavity, you can go for intraoral excision of the tumor. You might not need a radical resection. So if you are planning out for surgery, think about the access, what is going to be important. Then you are going to go for resection. If the resection margins are very much important, we already saw that the resections margin are minimum 5 mm. And if the tumor is going to be T3 or T4, then the resection margins are going to go to 1 centimeter. So we have already seen it in the yesterday's lecture. And then you are going to go for neck thinking. So if the neck is positive, if neck nodes are positive, you can go for MRND and then reconstruction if it is going to be required. So whenever you are going to go for a radical resection, the reconstruction is going to be required. And virtual surgical planning, nowadays softwares have come wherein you are going to feed the CT scans of the patient and it is going to deliver an output that how much amount of area is removed, what type of flap can be required and what type of resections can be done. Now we are going to talk about criteria for inoperability. So before operating the patient, before thinking about the operation, first you should know that which patients are not to be operated. So there are 4 reasons wherein you are not going to operate the patient. This patient is considered to be only and only for concurrent chemoradiation and remaining palliative care. So what are these patients? So it is a masticator space invasion. Sir, what is masticator space invasion? When the patient is involved into the spaces which are given here. So you can see this diagram very well represented. This is going to be the temporalis muscle. This is your temporalis muscle. And this is going to be the temporal fascia. So this temporal fascia is going to go and insert on the zygomatic arch. Here the zygomatic arch is going to give rise to the muscle which is going to be the masseter muscle. The masseter muscle is going to be in the superficial region. So between this there is a formation of the space. You can see this, that this is called as a masseteric space. So submasseteric space or masseteric space. So this is the space which is behind the masseter or deep to the masseter muscle. Hence it is called as a masseteric space. Here you can see an important muscle which is called as the lateral pterygoid. So this is the lateral pterygoid muscle and it is going to divide this infratemporal space into 2 regions. So one is called as a deep temporal space. So this space is called as a deep temporal space. So this is the deep temporal space and this space below the pterygoid muscle. So below the pterygoid muscle it is going to be the pterygomandibular because it is between the pterygoid muscles. This is the medial pterygoid, this is the lateral pterygoid and this is the mandible. So between this space there is going to be the pterygomandibular space. So these 3 spaces together, the deep temporal space, the masseteric space and the pterygomandibular space is going to comprise what is called as a masticator space. So whenever this region is going to be involved by the tumor, whenever you are going to resect this tumor, the patient will not have a jaw occlusion. So patient is not going to have any type of the mandibular movement. So it is going to be a very morbid procedure. So no, you are not going to resect this tumor. So pterygoid muscles, ramus or infratemporal foci is going to be involved. So if the pterygoid muscles are invaded, so pterygoid muscles are going to check for the opening and closing of the mandible and dental occlusion. But if pterygoid muscles are involved, the patient is already having severe trismus, resection would lead no functional jaw. So first thing is important that you are not going to add to the morbidity of the patient. The life of the patient should be increased. So no go for resection. Sir, if it is going to be a skull base involvement, naturally if the skull base is involved, there are a lot of cranial nerves exiting from the skull base. So you're not going to go for any resection. And last but not the least, it is going to be the internal carotid artery. So 360-degree carotid artery involvement, the resection would sacrifice the ICA and the patient will have a stroke later on and patient is not going to live a normal life. So this is the criteria for inoperability. Few books are also going to tell you about the retromolar trigon. So if the RMT is going to be involved, it can also be considered as inoperability. Few people are also going to consider the type of mass. So it is going to be a very big mass. It is going to require a lot of resection even from the floor of the mouth, even from a lot of mandibular structures are going to be involved. that is the time you can actually think of downstaging the tumor. सर आप मुझे एक चीज बोलो कि why don't you first downstage the tumor? अगर इतना बड़ा tumor है 10 centimeter का and you downstage it to let's say 2 centimeter by giving a concurrent chemoradiation and then you operate, why can't you do that for head and neck malignancies? So the reason is whenever you are going to operate on the head and neck malignancies, even after downstaging the tumor, the margin of the resection is to be taken which was there on the first diagnosed scan. So whenever you are going to operate a patient of oral CA, the first thing you are going to do is you are going to refer it to the first diagnosed scan of the patient और margin पहले का लेने का. NSCT देने के बाद अगर ट्यूमर छोटा हो गया तो मैं उतू सा margin ले लूंगा नहीं. You have to take the margin which was there previously before starting the chemotherapy. So that is the reason why irrespectively, even if this patient is going to have downstaging because of chemotherapy, you cannot resect these 4 structures and hence the patient is going to be inoperable at all cost. So that is the patients where you are going to exclude the patient and not give amount any type of surgical advice to these patients. Refer it to for concurrent chemoradiation. So I hope it is very much clear to you. Now when we are talking about it, the first thing which is going to come is the airway assessment. So whenever a patient is going to come to you, whenever you are planning a surgery, first you are going to think about the airway assessment. क्या देखने का airway assessment पे? Lateralized tumor है, not invading the proper oral cavity, not involving proper your trachea or the central lesions, you can just go for upfront surgery and the patient can get extubated as it is. So lateral lesion is में intubate रखने का जरूरत नहीं है. But the central tumors, the floor of the mouth tumors, the problem is after going for resection, there is there is exacerbative edema development in this region and patient post-operatively 24 to 48 hours के बाद में desaturate हो सकते हैं because the patient is going to have a lot of edema here. So low threshold for tracheostomy. So if you feel that the patient's airway might be compromised after surgery, so don't do tracheostomy in the ICU, do it on the table. So if bilateral edema is going to risk the airways and tongue base involvement, bilateral neck dissection, so it is going to cause a compound swelling and edema and hence you have to go for a tracheostomy upfront. Bilateral neck dissection karoge, again edema chances are going to increase, lymphatic obstruction is going to be there and because of that the patient is going to have significant edema. So any edema in the floor of the mouth is going to obstruct the airway and you are going to go for a tracheostomy. If you are going to do a free flap reconstruction for the floor of the mouth, so you know that the floor of the mouth, the mandible, the hyoid muscles are going to keep the trachea pulled up and it is going to help in deglutition. So floor of the mouth agar tum remove करने वाले हो पूरा का पूरा, then that is the time when you are going to need some flap, and when the flap is going to come till it is going to take over the normal function, you need to keep the patient tracheostomized. So elective tracheostomy is done. पहले बहुत बार तो पहले ही tracheostomy कर देते हैं and बाद में then you are going to operate for the surgery. So it is very much important. Difficult airway, if it is anticipated, you can do what is called as a awake intubation. So patient when he is awake, nasal intubation कर देने का patient का. So you know that the patient is going to be electively extubated. Patient is not going to have any complications post surgery, and post surgery you are going to extubate the patient and then you can go for a nasal intubation because the nasal intubation is going to help to assess the oral cavity. A surgeon can operate on the oral cavity without having compromise on the airway. So awake nasopharyngeal intubation can be done in this patient. So it is called as awake fiber optic intubation. Never attempt a laryngoscopy without in the awake patients or after radiotherapy. So if you have given concurrent chemoradiation to the head and neck region, then naturally the mouth opening is going to be low, the tissues are going to be friable. So while doing laryngoscopy you might injure the lesions and you might cause elective aspiration of blood. So that is the time when you should always go for awake fiber optic intubation of the patient. So I hope it is clear. So first thing you are going to do is an airway assessment. So now let's do a flow chart. So now let's do a small flow chart and tell how are you going to manage a patient of oral lesion. So whenever an oral lesion is going to come to you, so whenever a patient of oral lesion comes to you, if it is high risk features, if high risk features present, if high risk features are going to be present, you are going to do for a biopsy. Biopsy में क्या आएगा? It is going to be positive for malignancy. So when it is going to be positive for malignancy, you are going to do what is called as imaging. So क्या करोगे? CT plus USG neck. So CT में क्या पता चलेगा? First thing you are going to tell about it is operable. So हमने inoperability का criteria already देख दिया है. So criteria for inoperable disease. So अगर inoperable disease है, if the disease is going to be inoperable, irrespective to the nodal status, irrespective of everything, you are going to pose the patient for CTRT. It is going to be concurrent chemoradiation to the patient irrespectively. But if it is going to be operable, then you are going to think about then you are going to ask the patient about the first thing which is going to be the airway. So airway हम लोगों ने secure कर दिया, उसके बाद में you are going to plan the resection. So resection कैसे करना है, and then you are going to plan about the neck. MRND करना है कि नहीं करना है, एंड लास्ट थिंग देन यू आर गोइंग टू गो फॉर व्हाट इज कॉल्ड एज अ रिकंस्ट्रक्शन. एंड इधर रुकने का नहीं, इफ द ट्यूमर इज गोइंग टू हैव हाई रिस्क फीचर्स, सो इफ व्हाट आई एम टेलिंग, इफ द ट्यूमर इज गोइंग टू हैव हाई रिस्क फीचर्स, सो ये हाई रिस्क फीचर्स मतलब क्या, हिस्टोपैथ में जो हाई रिस्क फीचर्स आएंगे, व्हाट आर दोज, इट इज लिम्फोवैस्कुलर इन्वेजन, पेरीन्यूरल इन्वेजन, वी ऑलरेडी सॉ इट यस्टरडे. इफ इट इज गोइंग टू बी एक्स्ट्रानोडल एक्सटेंशन, सो ये अगर सब एक साथ होने वाला है, तो देन पोस्ट ऑपरेटिवली ऑल्सो द पेशेंट इज गोइंग टू रिक्वायर CTRT. सो पोस्ट ऑपरेटिव CTRT इज गोइंग टू बी रिक्वायर्ड. तो हिस्टोपैथ का रिपोर्ट लेके मेडिकल ऑन्कोलॉजिस्ट के पास भेजने का कि अगर इसको हाई रिस्क फीचर्स है, तो सर वुड यू लाइक टू गिव द पेशेंट CTRT. सो ही इज गोइंग टू से yes, then you are going to post the patient for adjuvant chemotherapy after the surgery. So adjuvant CTRT after going for proper resection. So this is going to be the flow chart of any patient who is going to be come to you. So now the patient is come, we have categorize the patient into operable. Operability के बाद में हम लोगों ने देखा कि पेशेंट को हम लोग कैसे अप्रोच करेंगे. So these are surgical approaches which are given in belly love. Might not remember it. Main concern is go for wide local excision with 1 centimeter margin. Sir और एक चीज मुझे बतानी है, any lesion in the oral cavity, any lesion in the oral cavity, if it is going to involve the muscle. So अगर inside the mucosa, so buccal mucosa में lesion है and it is going to invade the muscle of buccinator, so or the masseter, so any muscle involvement, then you are going to go for concurrent skin excision. So always remember as a golden rule that whenever any tumor is going to be there in the oral cavity which is going to invade any type of muscle, then वो muscle तो निकालना ही पड़ेगा, and उसके साथ में बाजू का skin का भी कोई रोल नहीं है. So along with the skin you are going to remove it. But if the muscle is not involved, only it is involving the mucosa and the submucosa of the oral cavity, then you can spare the muscle and you can just go for wide local excision of the region. You don't need to remove the muscle as well. So what important thing is, if muscle is involved, तो skin भी जाना ही जाना है साथ में. तो इतना प्यार है muscle और skin के बीच में कि अगर एक मरेगा तो दूसरे को साथ में लेके ही मरेगा. So that is the important thing which you should take home while doing planning the surgical resection. So one is wide local excision with proper margin, and if the muscle is involved you should go for concurrent skin excision. तो पूरा skin भी external region का निकालना पड़ेगा. So how do you go for intraoral approach? So one is lip split. So lip को हम लोग ऐसे tear करेंगे. One side of the lip can be teared and it can be lifted off. So it is a lip split or mandibulectomy approach. Rim mandibulectomy. So mandible को हम लोग एक rim में निकाल सकते हैं. So always remember when mandible. So few take home points. If mandible cortex is involved. So cortex if it is involved, then you can go for marginal mandibulectomy. So marginal resection of the alveolar margin is very much important. So let's consider that this is your mandible and this is the tumor. So this tumor is only invading the cortex and the medullary cavity of the mandible is intact. So you can just shave off the lesion. So you can just take this lesion and you can keep the mandible. So नया mandible ऐसे दिखेगा, कुछ तो ऐसे पतला सा mandible दिखेगा. So this is called as a marginal mandibulectomy. But whenever bone marrow is going to be involved, so whenever bone marrow is going to be involved, so whenever the tumor invades cortex into the marrow, and it has a frank bone excision, mandibular reconstruction, so segmental mandibulectomy needs to be done. So why it is important? If cortex is involved, marginal mandibulectomy. If marrow is involved, segmental, पूरा mandible का segment निकालना पड़ेगा. And how are you going to know if the segment is going to be involved? So MRI is going to tell if the marrow is going to be involved. Sir, bone marrow involvement कैसे पता चलेगा? So bone marrow, M for M, MRI is going to tell you if the bone marrow is going to be involved, and if it is going to be involved, you need to remove the full thickness of the mandible. So these are some take-home points which you should be knowing for surgical principles. Wide local excision, intraoral resection without mandibular access, small tumors, so T1, T2 tumors can be done intraorally. Rest all the tumors require either a lip split approach or you might go for a wide local excision. Mandible के बारे में हम लोगों ने already देख लिया है. Marrow involvement है तो you should go for a segmental mandibulectomy. Marrow involvement कैसे पता चलेगा? On the basis of MRI. Very much clear. Sir, neck dissection, we already saw that all oral cavity drains into level 1, 2 and 3, but exception is the tongue. The tongue is very naughty, it can directly drain into the level 3 and level 4 because of the foramen cecum, and hence for tongue you should go for what is called as you can go for modified SOHND. So nowadays the neck dissections have come down to three things. So initially there was a radical neck dissection. We saw the level of lymph nodes, level 1 to 5 remove करते थे. Nothing was preserved. Along with that we removed sternocleidomastoid, IJV and cranial nerves, spinal accessory nerve. But उनको पता चला कि by doing this radical dissection there is no additional benefit to the patient. So stay conservative. So what is conservative? They thought MRND करेंगे. What is MRND? Level 1 to 5 was removed. Preserve one or the more. So एक चीज अगर तुमने preserve की दोनों में से, leave the type 1, type 2, type 3, it is an outdated approach. So these days if you are going to only preserve either one of the structure or 2 or 3 of them, it is considered to be MRND. Nodal disease with therapeutic intent. But now if the nodal disease is absent, again remember what I am saying, if nodes are absent, they tell you that still go for neck dissection, but don't do a radical neck dissection. Only drain those lymph nodes which are involved. So अगर oral cavity में कहीं पे भी कैंसर है तो कुटला lymph node निकालोगे level 1, 2 and 3, and all these lymph nodes are above the omohyoid, so it is called as SOHND, supraomohyoid neck dissection. So only for oral cavity cancers you are going to go for what is called as SOHND. Exception कहाँ पे? Exception tongue, क्योंकि टंग में लेवल 4 भी इन्वॉल्व है. सो व्हाट यू आर गोइंग टू डू इन एनी ओरल कैविटी, इफ प्रोफाइलैक्टिक लिम्फ नोड डिसेक्शन विथ नो लिम्फ नोड्स पॉजिटिव, यू आर गोइंग टू गो फॉर SOHND. सो अगर ये टेबल में हम लोगों ने देखा तो नेक डिसीज के बारे में अगर हम लोगों ने देखा, सो इफ नेक डिसीज इज प्रेजेंट यू आर गोइंग टू गो फॉर MRND. But if neck disease is going to be absent, then you are going to go for SOHND, supraomohyoid neck dissection. उसमें हम लोग level 1, level 2 and level 3 निकालेंगे. And उसके साथ में if tongue is there, then you are going to take level 4 also along with it. So it is called as ESOHND. So extended supraomohyoid neck dissection. Extended supraomohyoid neck dissection. So just to revise, if neck nodes are clinically positive or if they are FNAC proven, you are going to go for MRND. So MRND में हमने देखा कि you can preserve the, you have to preserve the functional structures. It might be a spinal accessory nerve, sternocleidomastoid muscle और IJV. So जो involved नहीं है सबको बचाओ जितना possible है. But sir, clinically nodes are not palpable, clinically non-palpable nodes, and again the nodes are not there on the USG, and there are no nodes clinically, CN0 is the status. Then what to do? Nowadays they recommend that irrespectively you have to go for a neck dissection. कौन सा neck dissection करोगे? Selective neck dissection. So the oral cavity is going to drain into lymph node level 1, 2 and 3. So you are going to go for SOHND. But exception is again the tongue being the notorious factor here. Tongue is going to have drop metastasis because of foramen cecum to level 4. Hence you are going to go for ESOHND, which is going to be extended supraomohyoid, where you are going to also involve the level 4 lymph nodes. So this is the neck management for any patient of oral cancer. I hope it is crystal clear. So that is very much important. So radical neck dissection देखा, SOHND देखा. So what is SLNB? Sentinel lymph node biopsy में क्या होगा? It might have a false negative rate of 14%, and we saw that if the patient is going to have any lymph node disease, you are going to suspect the patient for CTRT. और तुम लोग क्या सोचोगे? अरे HP में तो कुछ भी high risk features नहीं, lymph node भी negative, don't give CTRT. But गलती से मैंने एक lymph node miss कर दिया क्योंकि SLNB was negative. Hence some center are going to go for selective lymph node dissection in T1, T0 with CT0, and if tongue SCC, standard remains care of elective neck dissection. So that is the reason with any oral cavity cancer you are straight away going to go for a neck dissection. Very much important. सर टिश्यू रिकंस्ट्रक्शन, व्हाट इज इंपॉर्टेंट? प्राइमरी क्लोजर अगर पॉसिबल है तो प्राइमरी क्लोजर करो. छोटा सा लीजन है तो यू कैन जस्ट गो फॉर अ प्राइमरी क्लोजर. लिप का प्रॉब्लम है, गो फॉर अ प्राइमरी लिप रिपेयर. बट इफ इट इज गोइंग टू बी अ मीडियम डिफेक्ट, यू नीड टू टेक ऑफ सम फ्लैप. So we saw that grafts are when they are not taken with blood supply, flap is with the blood supply. So whenever you are going to have a larger lesion, whenever smaller lesion, direct closure, or you can use a FAM flap. So what is a FAM flap? Facial artery flap. So any flap on the skin on the face is going to be based on the facial artery. So you can just take a flap and do a rotational flap, or you can do a VY plasty. We have already seen all those things in the plastic surgery. If it is going to be a medium defect, you need to take some amount of chunk of muscle. So कौन सा चीज यूज करोगे? So you are going to use a radial artery forearm flap. So we have already seen radial artery forearm flap. It is a thin flap and it senates the lateral cutaneous nerve of the forearm. And here you are going to always check that the patient's arm, which arm, if the patient is righty, don't go for a right side arm, go for a left arm when you are going to harvest the flap. Sir, large or bulky disease है तो you are going to prefer an anterolateral thigh flap. So anterolateral thigh flap is going to give a lot of muscle and fat. So if the defect is going to be large, you can prefer this flap. And tongue को reconstruct कैसे करोगे? So tongue को reconstruction करते हुए you can always, you are always and always going to use a, yes, you are going to use एंटेरोलैटरल थाई फ्लैप. इफ बल्की टंग और स्मॉल टंग अगर रहेगा तो रेडियल आर्टरी फोरआर्म फ्लैप. तो कोई किसी ने भी नींद से पूछा कि कौन सा फ्लैप आइडियल है, रेडियल आर्टरी फोरआर्म फ्लैप और एंटेरोलैटरल थाई फ्लैप, बेस्ड ऑन द साइज ऑफ द डिफेक्ट एंड चंकीनेस ऑफ द डिफेक्ट. सर हाउ आर यू गोइंग टू रिकंस्ट्रक्ट द टंग? सर छोटा डिफेक्ट है रेडियल आर्टरी फोरआर्म फ्लैप, बड़ा डिफेक्ट है एंटेरोलैटरल थाई फ्लैप. सर मैंडिबल को कैसे रिकंस्ट्रक्ट करूं? सो मैंडिबल को कैसे रिकंस्ट्रक्ट करूं? सो यू हैव टू आस्क टू थिंग्स इफ यू आर गोइंग टू पुट टीथ टू इट. सो इफ टीथ, अगर तुम्हारा प्लान है कि उसमें टीथ लगाना है तो यू कैन यूज अ आइलियक क्रेस्ट ग्राफ. सर आइलियक क्रेस्ट बोन ग्राफ्ट और कहा जगह मैंने यूज किया था? तो इफ यू रिमेंबर वी हैड यूज्ड इट इन व्हाइल रिकंस्ट्रक्टिंग द पैलेट ऑफ द पेशेंट इन क्लेफ्ट पैलेट. एंड इफ द टीथ इज नॉट गोइंग टू बी देयर, सो ऑलरेडी बुढ़ा है, उसके ऑलरेडी सब दांत चले गए हैं, तो यू कैन यूज फ्री फिबुलर फ्लैप. सो फ्री फिबुलर फ्लैप एंड आइलियक क्रेस्ट फ्लैप, सो आइदर ऑफ देम यू कैन यूज इट फॉर रिकंस्ट्रक्टिंग द मैंडिबल. सो ओरल कैविटी के लिए दो फ्लैप कौन से बोले मैंने? एंटेरोलैटरल थाई फ्लैप और रेडियल आर्टरी फोरआर्म फ्लैप. एंड अगर मैंडिबल रिकंस्ट्रक्ट करना है, टीथ है तो आइलियक क्रेस्ट फ्लैप, टीथ नहीं है तो यू आर गोइंग टू यूज अ फ्री फिबुलर फ्लैप. But remember that these flaps carry a risk of anastomosis dehiscence. They might go for necrosis. They might have some problems. They require a lot of monitoring. So in case the patient is unfit for such grafting and extensive surgery, you can straight away go for a PMMC. We saw that PMMC flap is a doubled pedicle flap. So you can remember those Mathis and Nahe classification. It was class 5. It had 2 dominant pedicles, and that is the reason why it has one dominant pedicle. Sorry, it has one dominant pedicle and another. These are the segmental blood supply. So these are called as a robust flap. Along with it, his brother was a latissimus dorsi flap. So if you can recall from the plastic surgery module, you can use a PMMC flap. It is a robust flap. It is going to survive. And if the patient is not having proper nutrition, if the patient is not having any proper care, there is not going to be a caretaker of the patient, you can go for a PMMC flap. That is also going to be fine. Mandibular reconstruction, free fibular flap is the gold standard, provides long segment for vascularized bone. And always remember that VSP is done. What is VSP? Again, it is a software, virtual surgical planning. Before actually going for surgery, you can enter all the details and you can check what are the dimensions of the plate required, what are the dimensions of the bone required. If not, if you are not going to go for a proper treatment to the patient, the mandible might protrude outside and that will cause what is called as anti-gum deformity. So anti-gum deformity mein, tumhara mandible is going to come more excess on the face, and that is the reason the patient is going to have a protruded mandible, like a protruded mandible, and that is the reason you are going to do a virtual surgical planning. And bone acts as an nidus of infection in the reconstruction, so meticulous planning is important, proper antibiotics are important. And again, as I said, iliac crest if you are going to go for a shortal segment with dentition. So if you are going to go for a dentition, and scapula with the soft tissue flap. So scapula के साथ भी flap तुम उठा सकते हो. But main thing, two things, free fibular flap. Second is yes, you are going to go for yes iliac crest flap. So दो चीजें हमें पता होना चाहिए. Sir, anti-gum deformity का opposite कुछ देखा था हमने last lecture में. क्या था वो? तो it was a Pierre-Robin sequence. If you could remember, it was associated with cleft lip, cleft palate, where the mandible was having retinognathia. The mandible was posteriorly placed, and that is the reason why tongue used to fall back and patient used to require a tracheostomy. तो उसमें हमने mandibular distraction करने वाले थे. यहाँ पे mandible बड़ा होने वाला है, तो it is called as an anti-gum deformity. So very much important for you to know. Great. तो जब मैक्सिला रिसेक्शन करने का टाइम आएगा, इट इज हाईली स्पेशलाइज सर्जरी. मैक्सिलरी सर्जरी नॉर्मली एक जनरल सर्जन के अंडर है, ऑन्को के अंदर नहीं आता. इट रिक्वायर्स अ प्लास्टिक सर्जन, ओएमएफएस सर्जन, अ फेशियल सर्जन. सो इट इज अ वेरी कॉम्प्लेक्स प्रोसीजर. यू शुड जस्ट नो दैट देयर आर 6 क्लास ऑफ डिफेक्ट्स इन द मैंडिबुलर मैक्सिलरी डिफेक्ट्स. सो व्हेनेवर यू आर गोइंग टू एक्सरसाइज द मैक्सिला, देयर आर गोइंग टू बी 6 क्लासेस ऑफ डिफेक्ट्स व्हिच आर राइटली शोन हियर. क्लास 1 अगर देखोगे तो जस्ट पार्ट ऑफ द मैक्सिला इज इन्वॉल्वड. क्लास 2 में नेजल कैविटी का पोर्शन आएगा. क्लास 3 में ऑर्बिटल कैविटी का पोर्शन आएगा. क्लास 4 में आईबॉल के भी कुछ स्ट्रक्चर्स आएंगे. 5 में मैक्सिला का नीचे का पार्ट बच जाएगा, बट इट इज गोइंग टू इन्वॉल्व द ऑर्बिट. एंड क्लास 6 में सेंट्रल पोर्शन विद नेजल कैविटी आएगा. सो बायलैटरल मैक्सिला आर गोइंग टू बी इन्वॉल्वड इन लेवल 6. सो दीज आर द 6 क्लासिफिकेशंस ऑफ द मैक्सिलरी डिफेक्ट्स. इट इज कॉल्ड एज अ ब्राउन्स क्लासिफिकेशन. सो पहले में मैक्सिला आएगा, दूसरे में मैक्सिला विथ नेजल कैविटी आएगी, तीसरे में मैक्सिला नेजल कैविटी विथ ऑर्बिट आएगा, चौथे में ऑर्बिट विथ कंटेंट्स भी आएगा, पांचवे में नीचे का मैक्सिला छूट जाएगा, और छठे में ओरल ऑर्बिटल कैविटी छूट जाएगी, दोनों साइड का नेजल कैविटी रहेगा. तो दिस इज अ ब्राउन्स क्लासिफिकेशन. सिमिलरली हियर A, B, C, D, it is based on the palate defect. Not important for you to know at your UG level, even somewhere at the PG level they might just ask you. You should know that Brown's classification is there. So here they have given how to reconstruct the flap. It is typically given in Bailey Love. Very much important if you are planning to go for a plastic surgery as a super specialty. Not required at your level. If you can remember, it is there in the PDF. Not remember, just leave it. But you should know कि भावना उसके पीछे का क्या है. What are the Brown's defects? Because it is given in Bailey Love, might come for you in your NEET PG that the maxillary defects classification is according to dash. Sir, maxillary fracture classification, Lefort classification, maxillary defects classification, Brown's classification. तो उसके हिसाब से हमें पता होना चाहिए कि what is the ideal thing to do. सर हमने TNM staging ऑलरेडी देख लिया है. TIS is carcinoma in situ less than 2, 2 to 4, more than 4. But here what is important is depth of invasion. So DOI less than 5 mm, 5 to 10 mm and here more than 10 mm. And if the tumor is going to be T4B, so T4B means inoperable structures. Inoperable structures कौन सा? Masticator space, pterygoid muscles, तीसरा क्या था? ICA and base of skull. So ये चार चीजें अगर है तो it is going to be non-resectable, and it is very much important that whenever you are going to give a CTRT to the patient, then plan surgical excision, the margin to be taken is going to be the first margin and not the margin after the tumor shrinkage. Very much important. Lymph node में N1 में same side node less than 3 cm, N2 is going to be N2A में 3 to 6, N2B में more than 6, N3 is going to be contralateral node less than 6 cm, and N3 is going to be metastasis in nodes which is going to be more than 6 cm in diameter. So very much important for you to know that N1, N2 and N3 very much important. M1 is distance met, M0 is no metastasis. So this is the TNM classification. Factual thing रट्टा मारना पड़ेगा, कर लो, समझ गए? What is the role of adjuvant therapy? So adjuvant therapy किस में देने का? We already saw that the lesion, clinically high risk lesion कौन से रहते हैं? More than 6 weeks present, if they are going to have some induration, if they are going to have some adjacent, what do you say, trismus, if they are going to have some adjacent, what you can say, the sensation or problem with the sensation, ये सब चीजें clinically relevant है to rule out malignancy. Biopsy में और surgery के time पे कौन सी चीजें दिखेगी? Which will classify the malignancy to be high risk. So lesion was high risk with some other factors. Now the malignancy is going to be high risk because of these factors. Extranodal extension, lymphovascular invasion, multiple lymph nodes are going to be involved, perineural invasion or positive surgical margin. So if you are not going to have a surgical margin positive adequacy, minimum 5 mm and T3 T4 1 cm, then it is going to be considered to be a high risk lesion or T3 T4 tumor. So any T3 T4 tumor, we know that T3 T4, we know that depth of invasion is going to be 10 mm when you are going to classify T3 T4 tumor, or if the surgical margin is inadequate, you are considered to this lesion that it is a high risk lesion and you are going to go give the patient concurrent post operative chemoradiation. पहले बस radiation देते थे. Initially they used to give only radiation, but the protocol changed later on, and that was the trial which is called as RTOG trial and EORTC trial. Sir, trials important है? Yes, for a resident important, for NEET SS important, not important for PG level, UG NEET PG level. So what did they do? As I told you already, they gave cisplatin. So cisplatin देने के बाद में radio sensitization होता है, and because of that the concurrent chemoradiation, so cisplatin based concurrent chemoradiation had significant better results than radiotherapy alone. So ये दो trials थे. Sir, what is the difference between the trial? Sir, if you know that yes, the RTOG trial only and only are going to be involved, only to limited criteria. So it was limited criteria, but here they had extended criteria. So what is an extended criteria? तो ये सब चीजें उन लोगों ने एक साथ ली, and all these things came into the extended criteria. Initially they used to check only for ENE or LVI. So ये अगर दो चीजें ही है patient को, they used to consider high risk. But later on what they did, they included all the patients with nodes positive, T3 T4 disease, perineural invasion, lymphovascular invasion. So they extended the criteria, involved more patients in the study, and they found out that whenever you give concurrent chemoradiation with cisplatin based therapy, the results are going to be superior. And immunotherapy, always remember that immunotherapy, अभी सब जगह पे immunotherapy आने लगेगा. 5 साल बाद जब ये lecture series में वापस लेने का कोशिश करूंगा तो सब इसमें मैं immunotherapy बोलूंगा. So immunotherapy में हम लोगों ने already देखा था what is the molecule. It is the PD-L1 molecule which is going to be very much important, or CD4 molecule. These molecules are going to be present on the cells and it is like a ticket checker. So immunotherapy मतलब रेलवे टिकट याद आने का. टेररिस्ट के पास में फेक टिकट एंड फेक पासपोर्ट है. अगर तुम वो फेक पासपोर्ट को बैन कर दोगे, वो पासपोर्ट उसका घुमा दोगे, you are going to place a drug on that fake receptors which the cell is having. Naturally the T cell is going to destroy that cell. So ticket checker को पता चल गया, उसने उधर ही टेररिस्ट को उड़ा दिया. So we already have seen it very well in the case of multiple melanoma. So it has shown positive results. So promising result आए हैं. तो might be Bailey Love 29th edition में जब आएगा तो immunotherapy will be the gold standard because the meta-analysis will be conducted and naturally included in the textbooks and in your syllabus as well. So immunotherapy is the upcoming future. Never miss out on any topics of immunotherapy. क्या ही करना है, छोड़ दो immunotherapy. नहीं, immunotherapy is the future. Even it might come in the exams and also in your practice, day-to-day practice. Might be when you will be practicing as an oncosurgeon or you will be practicing as a medical oncologist, immunotherapy is going to come down to the rescue. So it is very much important for you to know. So now coming down to the salivary gland. So salivary glands topic is more important than oral C, I would say, because salivary gland has 3 glands. It has a lot of different anatomy, preservation of much structures, and the gland anatomy is very complicated. So I'm going to try to simplify the gland anatomy and we'll try to make this as happening as possible. So जितना हो सके आज करेंगे, बचा हुआ salivary glands कल करेंगे. So embryology and secretion. So remember that parotid is the exception. Parotid is going to be the yes, as we say, it is a high risk obstetric precious pregnancy. So जैसे वो child को हम लोग बहुत अलग से पाल पोस के बड़ा करते हैं, वैसे ही parotid है. सब glands are endodermal, but the parotid is going to be ectodermal. So अकेली gland unique. Secretions देखोगे बस serous secretions करेगी. Duct भी देखोगे तो it is the Stensen's duct, this is going to be the Wharton's duct, this is going to be the multiple small ducts. Next इसमें diagram दिखाता हूँ. And it is going to be opening at the opposite of the upper second molar tooth. This is going to be in the sublingual region, and these are minor salivary glands are going to open, and the sublingual gland is going to open directly into the floor of the mouth. So very much important. So here if you are going to see, this is going to be the parotid gland. तो ये parotid gland अगर तुम देखोगे तो this is the parotid gland. Three important structures when it comes to the parotid gland. One is the facial nerve. Facial nerve. Second is going to be your external jugular vein. EJV is going to form behind the gland, and ECA is going to terminate behind the gland. So these are the structures which you are going to encounter as you go superficial to deep. So पहले facial nerve लगेगी dissection करते वक्त, फिर IJV लगेगा, फिर ECA लगेगी. So here if you can see it properly. So let's label of the structures which we can see here. What are the structures we can see here? This is going to be the duct. This is going to be the facial nerve. This is going to be the formation of the external jugular vein. So here the external jugular vein is formed. Here it is going to be the bifurcation of the carotid artery. So ये external carotid artery gland के एकदम deep जाएगी. So superficial to deep पहले nerve आएगी, then you are going to have the vein, and then you are going to have the artery. So very much important for you to know anatomically. So facial nerve is going to be divided into the gland, and the gland is going to be divided into the superficial and deep lobes because of the facial nerve. And that plane where the gland is going to divide into the superficial and deep lobe, it is going to called as a Patty's faciovenous plexus, because it is going to have the facial nerve, and it is going to have the vein, the retromandibular vein, and formation of the external jugular vein. So it is called as Patty's faciovenous plexus, or Patty's faciovenous plane. The retromandibular vein lies deep to the facial nerve, and it is used as a landmark to find the nerve trunk. So मैं एक चीज बताने वाला हूँ, how are you going to trace the facial nerve inside that surgery of parotid? Lymph nodes. Majority lymph nodes lie just inside the parotid itself. So the gland itself has its own lymph nodes, and then they are going to drain into the deep lobe, and then they are going to drain into the deep cervical lymph nodes. So normally maximum salivary gland tumors are going to have the lymph nodes which are going to be embedded inside the gland itself. Parasympathetic supply. Sir facial nerve उधर से जाएगी. Normally बचपन में सीखा था anatomy में कि सर जहाँ जहाँ से जो nerve जाती है वो supply देती है, but इधर exception है. Facial nerve is not going to supply the parotid gland at all. Parotid gland को कौन supply करेगा? Sir, parotid gland is going to be supplied by the, yes, it is going to be supplied by the lesser petrosal nerve, which is going to be a branch of glossopharyngeal nerve. So glossopharyngeal nerve दूर दूर तक gland से कोई connection नहीं रखती है, but it is going to supply the gland. The parasympathetic supply is come from the glossopharyngeal nerve. So parasympathetic supply from cranial nerve 9, it is going to be coming from the tympanic plexus, lesser petrosal nerve, otic ganglion, and auriculotemporal nerve. So this is very much important for you to know. Parotid borders: anteriorly masseter, inferiorly posterior belly of digastric, superiorly there is the temporalis muscle, and posteriorly there is going to be the sternocleidomastoid. So चारों जगह से muscle ही muscle है. Posteriorly this is the sternocleidomastoid muscle. So let's give it in the green. So this is the sternocleidomastoid muscle. Anteriorly sir ये muscle कौन सा है? This is going to be the masseter muscle. This is the masseter muscle. Sir उसके deep ये कौन सा muscle है? It is the buccinator. So anteriorly masseter, inferiorly and posteriorly sternocleidomastoid. ऊपर अगर देखोगे तो this is going to be the temporalis muscle. So सब जगह से मसल ही मसल, masseter muscle, sternocleidomastoid muscle, temporalis muscle. And अगर तुम लोग इधर देखोगे तो here there is going to be the inferior belly of digastric. So this is the inferior belly of digastric muscle. Very much important for you to know. All these muscles are very much important. So this is the posterior belly of digastric muscle. So this is the posterior belly of digastric. So this is the posterior belly. सर ये कौन सा मसल है? ये अगर posterior belly of digastric है, ये अगर posterior belly of digastric muscle ये है, तो which is this muscle? Can anybody name it? Which is this muscle? So yes, this is nothing but stylohyoid. Coming from the styloid process, inserting on the hyoid bone. So two muscles come. So one is the posterior belly of digastric, and उसके साथ आएगा stylohyoid muscle. Very much important when you are going to name the anatomy. So let's clear this diagram off. So now one important thing which you are going to start. How are you going to trace the facial nerve while you are going to operate on the patient? Sir, facial nerve को तुम कैसे ट्रेस करोगे जब तुम पैरोटिड सर्जरी कर रहे हो? तो there are few things to it. So one is the tragal pointer. So one is the first important thing is a tragal pointer. So tragal pointer is nothing but this is going to be the tragus, and tragal के deep region में अगर तुम देखोगे तो 2 centimeter inferior and deep. So 2 centimeter inferior and 2 centimeter deep, you are going to find the facial nerve. So that is the first and most important thing which you can see, but remember that it is tedious to go. Hence the second landmark is going to be the nerve is going to lie just above the posterior belly of digastric. So digastric को तुम अगर posteriorly trace करोगे तो it is going to go and insert like this. So this digastric के ऊपर ही अगर देखोगे तो ये facial nerve के branches रहने वाले. So trace on the posterior belly of digastric. The third important point is going to be just anterior to the टिम्पैनोमास्टॉइड सूचर. सो यहाँ पे मास्टॉइड रहेगा, उसके एंटीरियर ट्रेस करोगे तो वहां तुम्हें नर्व मिलेगी. सो दीज आर द लैंडमार्क्स व्हिच आर नॉट गोइंग टू चेंज, बट द लैंडमार्क्स व्हिच आर गोइंग टू चेंज आर गोइंग टू बी द ग्लैंड एंड द नर्व. सो दीज लैंडमार्क्स जिसके हम आजू बाजू घूम रहे हैं वो लैंडमार्क्स चेंज नहीं होने वाले. सो टिम्पैनोमास्टॉइड सूचर. सो टिम्पैनोमास्टॉइड सूचर. And then the fourth is you can go for a stylomastoid foramen, which is again it is deep in nature. So जब तक उधर पहुंचोगे तब तक नर्व ही टूट जाएगी. So stylomastoid foramen, from where the nerve is coming. सर अगर ये भी करके मुझे नर्व नहीं मिल रही है, सर क्यों नहीं मिल रही है? क्योंकि ऑलरेडी उधर एक ऑपरेशन हो चुका है, ऑलरेडी देयर इज गोइंग टू बी अ लॉट ऑफ फाइब्रोसिस, एंड देन हाउ आर यू गोइंग टू स्टिल ट्रेस द नर्व? देन यू कैन गो फॉर द ब्रांचेस. सो अगर ये ब्रांच को मैं ट्रेस करूंगा, ये ब्रांच को ट्रेस करूंगा, ये ब्रांच को ट्रेस करूंगा, दीस 5 ब्रांचेस कैन बी ट्रेस्ड. सो हाउ आर यू गोइंग टू डू? यू कैन गो इन द रेट्रोग्रेड मैनर. So in cases of the recurrent surgeries or when there is going to be radiation and fibrosis, you can go for what is approach is called as retrograde tracing of the nerve. सर आज के जमाने में कहाँ ये यूज करोगे? Yes, today we are having nerve monitors. So nowadays you can actually do what is called as intraoperative nerve monitoring. So we already saw the detailed anatomy of the parotid gland, and this question is going to typically come to you while you are writing your surgery paper. Sir, how are you going to trace the facial nerve? So facial nerve trace करने के लिए antegrade approaches and retrograde approaches. So these are the antegrade approaches. Antegrade approach, the retrograde approach, and then comes the nerve monitoring, which is going to be the latest option. So latest option अगर किसी ने बोला, recent advances किसी ने पूछा, तो yes, it is going to be the nerve monitoring. So I hope it is clear. So that is all about the parotid gland. Now we are going to talk about the submandibular gland. Sir, submandibular gland तो और डेंजर है क्योंकि उधर और भी नर्व्स है और भी डेंजरस एनाटॉमी है, तो कुछ कोई प्रॉब्लम नहीं, वो भी हम छुड़ा देंगे, कोई बात नहीं. So this is going to be the submandibular gland. So submandibular gland के मैंने 2 sections लिए हैं. So one is from the lateral aspect. ये mandible अगर मैंने टूट के निकाल दिया तो this is going to be the lateral aspect of the gland. So this muscle which you are seeing is the mylohyoid muscle. So this is the mylohyoid muscle, and mylohyoid muscle के just तुमने अगर देखा तो उसको एनकेस करती हुई, उसको पकड़ते हुई जो ग्लैंड है, तो पोस्टीरियरली एनकेसिंग द ग्लैंड इज कॉल्ड एज द सबमैंडिबुलर ग्लैंड. तो दिस इज द सबमैंडिबुलर ग्लैंड. तो मैंडिबल निकालने के बाद ही दिखेगी अंदर, दैट इज व्हाई इट इज कॉल्ड एज अ सबमैंडिबुलर ग्लैंड. सो फर्स्ट इंपॉर्टेंट थिंग, दिस इज गोइंग टू बी द सबमैंडिबुलर ग्लैंड. सर आउटसाइड से अगर मैं देख रहा हूं तो क्या क्या दिख रहा है? तो दिस इज प्रीडोमिनेंटली सबमैंडिबुलर ग्लैंड, एंड ऑलवेज रिमेंबर दैट हियर फ्रॉम हियर देयर इज गोइंग टू बी क्रॉसिंग ऑफ द फेशियल आर्टरी एंड द फेशियल वेन. सो फेशियल आर्टरी एंड फेशियल वेन आर गोइंग टू गो फ्रॉम हियर, एंड along with that from the below the ramus of the mandible is going to go the marginal mandibular nerve. So whenever you are going to go for resection of this gland, you are in risk to injure this structure. तो सर मैं एक ट्रिक बताऊंगा आपको जिसके वजह से you can go for preservation of this marginal mandibular nerve. Sir, how are you going to preserve the marginal mandibular nerve? We know that face has extensive blood supply coming from the maxillary artery as well, from the facial artery of both the sides. So already इतना extensive blood supply है, तो मैं एक साइड का facial artery तो बिंदास उड़ा सकता हूँ, मुझे कोई टेंशन नहीं. तो मैंने क्या कर दिया, मैंने facial artery को इधर और इधर ligate कर दिया, एंड मैंने ये facial artery को ऐसे रिफ्लेक्ट कर दिया. So when I am going to reflect the facial artery, when I am going to reflect the facial artery, it is going to hook this marginal mandibular nerve, and it is going to lift the marginal mandibular nerve. So whenever you are going to go for a submandibular dissection, always remember facial artery को ligate करो, pass near, मतलब away from the gland, near to its origin, and then reflect it above. So that is called as Martini's maneuver. So whenever you are going to do this maneuver, you are going to lift the gland above. That is very much important for you to know. So what are the nerves which are going to come in between? The first is the lingual nerve. So lingual nerve, it is going to hook under the Wharton's duct as it is going to cross. So अगर हम लोग अंदर से देखेंगे, so we are going to see the submandibular gland from inside. So this is going to be the deep portion. Again, this is the mylohyoid muscle, and here is going to be the duct of the submandibular gland. So this is going to be the duct of the submandibular gland. And remember that जैसे उधर नीचे marginal mandibular को मैं facial artery and nerve से vein से hook करूंगा, either this nerve, this lingual nerve is hooking along the duct. So it is important for you to know that submandibular gland ki anatomy is very much important. It is very much cumbersome to know. And this is the sublingual gland, which has multiple ducts opening directly into the floor of the mouth. So very nice diagrams, both of them, which are going to explain the gland anatomy in the very good manner. So hypoglossal nerve, it is going to come when the facial nerve is going to be originated. It is below the gland and exposed when the gland is superiorly retracted. So again, it is going to be at the carotid bifurcation. Sir, where did we see the hypoglossal nerve? Sir, hypoglossal nerve हमने कल देखा था when we saw the Chamblin's classification. So near the bifurcation of the carotid कौन सी नर्व दिखेगी? मुझे hypoglossal nerve दिखेगी. Must be preserved, नहीं तो वो tongue paralysis होगा. Deviation of the tongue to the same side. So right side का अगर मैंने hypoglossal nerve injure किया, tongue will be deviated to the right side. Marginal mandibular nerve. So marginal mandibular nerve. Here important point to note is that it is going to run along the facial vein above and lower 1/3 of the mandible. So here what we have literally shown in the diagram, that this is going to be your marginal mandibular nerve. So this is the marginal mandibular nerve, and the facial artery and facial vein are going to cross. So you are going to ligate this facial artery and facial vein here. You are going to ligate them here, and after you are going to ligate them, this facial artery and vein can be lifted. And ये जब तुम lift करोगे तो ये marginal mandibular nerve automatically hook हो जाएगी, and it is going to be preserved, and it is going to be called as Martin's maneuver. So very important for you to know Martin's maneuver, that when you are going to ligate the facial artery and vein and hook it, that is called as Martin's maneuver. To preserve which nerve? To preserve marginal mandibular nerve. So one MCQ, what you can say, a point for you, that marginal mandibular nerve can be preserved by which maneuver? It can be preserved by Martin's maneuver. Facial artery we saw, facial vein we saw, Wharton's duct we saw. It is going to lie medial to the hyoglossus muscle. So hyoglossus muscle is going to be more medially. So here we can see this diagram. तो इसके आगे hyoglossus muscle रहने वाला है. Hyoglossus muscle is going to be more medially, and then this is going to be the mylohyoid muscle. Mylohyoid muscle को ही hug करते हुए जो gland है अपनी, that is the submandibular gland, and it is related with three nerves. One is the lingual nerve, which is related to the duct. The other nerve is the marginal mandibular nerve, which is going to come anterior to the, or the superficial to the gland. And the third important nerve is the hypoglossal nerve, where the carotid is going to bifurcate. उधर वो nerve हमें मिलने वाली है. So these three nerves are very much important when you are dealing with the submandibular gland. I hope the things are very much clear to you, and the anatomy is pretty much clear. So again, देख लो ये दो photos, चाहिए तो screenshot निकाल दो. तुम्हारे PDF में mostly नहीं रहने वाले ये photos. So just make a screenshot and then you can go ahead. So that is about the nerve. So now we are going to talk about some benign disorders of the salivary glands. Malignancy कल करेंगे, आज benign disorders करके खत्म करेंगे. So Sialolithiasis. So Sialolithiasis is the salivary gland calculus. So salivary gland calculus is called as Sialolithiasis. So what is Sialolithiasis? It affects the submandibular salivary glands. And क्या होता है? Mostly submandibular salivary glands क्यों? Because it has the anti-gravity drainage. So already we saw that the duct is draining so much into the anti-gravity fashion. So एक तो इतना लंबा duct, that too in the anti-gravity. Persistently you are actually going to be, even if the patient is going to sleep, it is again going to go anti-gravity, because ये सब चीजें ऐसे fall back होगी. So you can see this when the patient is going to sleep, ये ऐसे होने वाला है. तो फिर भी if you are going to see, it is going to be anti-gravity drainage. So whenever you are going to check the patient, the submandibular glands are the most common affected glands because of the Sialolithiasis. Submandibular glands are the most common affected glands. What are the risk factors? It is because of the chronic dehydration. It is going to be because of chronic dehydration, reduced salivary flow or medication. So anticholinergics अगर दोगे, diuretics दोगे तो patient dehydrate हो जाएगा और submandibular salivary gland के stones होने वाले हैं patient को. Due to anti-gravity drainage, high mucosal content, and due to alkaline secretions. So in alkaline secretions, you can see that the patient is going to have calcium precipitation more. So very much important point when you are talking about submandibular salivary gland stones. Remember treatment क्या रहता है? So whenever the stone is less than 7 mm, you have to go for sialoscopy. So endoscopy करते हैं, sialoscopy. Oral surgeons have a typical scope which is going to go from the ducts. The parotid duct में भी जा cannulate हो सकता है, and it can even cannulate the submandibular gland duct. The patient is going to present with the heaviness in the gland. Typically one complaint is going to be that the patient is going to have pain after chewing. So chew करने के बाद में इधर एक heaviness आता है, fullness आता है, and the patient is going to have submandibular pain. So it is the most characteristic sign of Sialolithiasis. How are you going to diagnose? The investigation of choice is the sialography. So you are going to inject the dye into the duct and then you can see the duct. So it is diagnostic as well as therapeutic. Because when you are going to push the dye, naturally the stone is going to go back into the gland and it might get dissolved later on. So it is always going to be diagnostic as well as therapeutic. Sir, less than 7 mm stone है तो साइलोस्कोपी से निकाल दो. 7 to 15 mm है तो you can go for transcutaneous excision or you can go for lithotripsy. More than 15 mm stone है तो lithotripsy करो. अगर नहीं काम कर रहा है तो gland excise कर दो. वेरी मच इंपॉर्टेंट. सर ग्लैंड एक्सरसाइज करना है क्यों? क्योंकि अगर वो रहा तो क्रॉनिक इरिटेशन होगा एंड इट माइट डेवलप इनटू अ सलाइवरी ग्लैंड ट्यूमर. सो नेवर कीप द स्टोन इन द ग्लैंड. अगर 7 mm से लेस है तो यू कैन गो फॉर अ साइलोस्कोपी. इफ 7 to 15 mm है यू कैन एक्चुअली गो फॉर एक्सट्रैक्शन वाया द इंसिजन और गोइंग फॉर द ट्रांसओरल रूट. इफ इट इज इवन मोर देन 15 mm देन यू कैन गो फॉर व्हाट इज कॉल्ड एज अ लिथोट्रिप्सी. इफ लिथोट्रिप्सी इज स्टिल नॉट फंक्शनिंग देन यू कैन गो फॉर द ग्लैंड एक्सिजन. सर स्टोन इन द डक्ट विथ वायबल ग्लैंड है तो स्टोन रिमूवल करो. अगर सलाइवरी एंड ऑलवेज रिमेंबर दैट ट्राई टू प्रिजर्व द ग्लैंड इफ possible, but not, then you can straight away go for excision of the gland. कोई भी सलाइवरी ग्लैंड का डक्ट का इंजुरी है, अगर पेशेंट ट्रॉमा में गया, अगर पेशेंट कम टू यू विद आफ्टर अ सर्जरी विद सलाइवरी ग्लैंड डक्ट इंजुरी, द पेशेंट इज गोइंग टू हैव समथिंग कॉल्ड एज एन एक्स्ट्रावजेशन सिस्ट. तो क्या बोलते हैं उसको? एक्स्ट्रावजेशन सिस्ट या फिर हम लोग रैन्युला या फिर व्हाट इज म्यूकोसील. तो ये सब चीजें हम लोग अभी थोड़ी देर में देखेंगे. व्हाट आर द डिफरेंसेस बिटवीन अ रैन्युला म्यूकस एक्स्ट्रावजेशन सिस्ट एंड अ म्यूकोसील. तो ये सब चीजें देखेंगे. बट इफ द डक्ट इंजुरी इज गोइंग टू बी more than 72 hours, always more than 72 hours, you are going to go for ligation of the duct and excision of the gland. Because after 72 hours you cannot reconstruct the duct. But if the duct injury is identified within 72 hours, you can go for a primary repair of the duct. Very much important point when you are dealing with salivary gland. If the duct injury is within 72 hours, you can go for what is called as primary repair of the duct. But if the duct injury is more than 72 hours, then you cannot repair the duct by any means. All is going to fail and it's better to go for excision of the gland. Because एक gland निकलने से कोई problem नहीं होगा. There are going to be innumerable salivary glands in the mouth. So you can go for salivary gland excision. Sir, what is sialidinitis? So it is inflammation of salivary glands, typically mostly seen in the parotid gland. So जैसे stones are common in submandibular gland, the parotid gland is more going to be prone for infection. So viral sialidinitis most commonly seen in mumps. So it is parotid only. It is bilateral. So whenever it is a viral disease, mostly it is going to be a bilateral disease because it is a systemic illness and it is bilateral parotid swelling. And remember that the main problem is not here. The main problem is down. The patient is going to have testicular problem because the patient is going to develop orchitis and patient might land up into infertility later. So bumps diagnose करोगे तो straight away pediatrician को refer करो. खेलते मत बैठो क्योंकि patient को problem गालों का नहीं नीचे का है. So it is very much important for you to know that whenever there is a problem, refer to the pediatrician to give that anti-mumps treatment whatever is required at that time. Even I don't remember pediatrics now, but important factor that refer the patient to a pediatrician. Supportive care, analgesia, hydrations, antivirals are not routinely used, but the what do you say? The decision of using an antiviral should be taken by a pediatrician. Bacterial sialidinitis, it might be unilateral. Always remember gram-positive cocci are causative agents. We saw that Staph aureus जहाँ पे होगा वहाँ पे there will be formation of abscess. But gram-positive diplococci या gram-positive cocci रहेंगे in chains like streptococcus. Streptococcus are going to cause cellulitis. So cellulitis with chain organisms and abscess with cluster organisms. So Staph aureus, unilateral pus expression from the duct orifice. So when you are going to press the gland and check the oral cavity, there is going to be coming out of small pus, and always it is important that elderly patients are at risk because of dehydration or because of chronic infection or immunosuppression. So you can give IV antibiotics, CT if abscess is suspected. So if it is going to be an abscess, you are going to go for drainage of the abscess. In childhood recurrent sialidinitis, remember that few patients might have some autoimmune condition in the childhood which is going to resolve when the child is going to grow. It is called as childhood recurrent sialidinitis. The cause is unknown and possibility congenital duct anomaly. So as the child is going to grow, the duct is going to mature, the recurrent attacks are going to reduce. So repeated parotid swelling on eating are seen in childhood. But all the USG is going to be normal, all the studies are going to be normal, even MRI might be done which is normal. So nothing is problematic. So you can just wait and watch. Sialography might be done or antibiotics can be given for acute episodes. बट बच्चे को कभी मत बोलना तुम्हारा ग्लैंड निकालना पड़ेगा, नहीं तो बच्चा तुम्हारे पास वापस कभी आएगा नहीं. एंड ही विल मिस आउट 10 पेशेंट्स ऑन यू. बाद में बोलेगा ये डॉक्टर के पास मत जाओ, कुछ भी रहे निकालने को बोलता है. सो रिमेंबर, व्हेन अ salivary gland excision needs to be done, when the stone excision needs to be done, when the salivary gland tumors are to be treated, and when the what you can say benign diseases are kept to be conserved, managed. Chronic cellulitis because of duct stricture. So repeated duct stricture, it is going to cause recurrent attacks and it is going to cause fibrosis and chronic inflammation. So gland is recurrently going to go for fibrosis and atrophy and treat the underlying cause, and gland excision if the management is going to be failed. So if the management is going to fail, then you are going to go for duct excision. Acute necrotizing sialometaplasia. So this is one disorder which can be mimicked with malignancy. So malignancy can actually mimic this disorder, typically seen with the palatine minor salivary glands. So we know that salivary glands can be major or minor. Major salivary glands मतलब कौन से, parotid, submandibular, sublingual. But जो palate पे glands रहेंगे, these are going to be minor salivary glands, and these minor salivary glands can develop an infection which or a condition which is called as acute necrotizing sialometaplasia. So these glands are going to have rapid turnover, and it is because of the vascular compromise usually seen on the palate. Reasons are not known. It mimics malignancy because it has necrosis as well as hyperplasia. So you are going to go for a biopsy to rule out a malignancy. It is very much important. So biopsy to rule out malignancy, and just reassurance is very much important. Sir, one point about while going that we are going to talk about the Sjogren syndrome. So what is the Sjogren syndrome? So we know that it is an autoimmune condition which is going to affect the salivary glands predominantly, salivary glands plus lacrimal glands. So dry eye and dry mouth. So we have already seen this in your autoimmune disorders and medicine disorders, that dry eyes and dry mouth is the Sjogren syndrome. So Sjogren syndrome में दो conditions आएंगे. One is primary Sjogren's and other is secondary Sjogren's. Sir, what is primary Sjogren's? Primary means बस eyes and mouth affected है, बाकी कुछ भी उसके साथ नहीं है. So primary Sjogren's when only eye and mouth are affected, rest all things are normal. And secondary Sjogren's when it is associated with systemic disorder, जैसे scleroderma हो गया, rheumatoid arthritis हो गया, SLE हो गया, उसके साथ में अगर it is going to be present, it is going to be called as a secondary Sjogren's. So here the xerostomia might be present, but it is less severe. In primary Sjogren's, it is very much going to be severe. So what are you going to do? We know that it is an autoimmune condition. It is a self-destruction of the gland. So here what you have to go for an immunosuppression. So give glucocorticoids and hydroxychloroquine first. So hydroxychloroquine is also used for treatment of SLE. And then you might add rituximab or methotrexate. You know that rituximab is anti-CD20 molecule, and it is going to block the antibodies from binding. It is going to prevent the B cell from proliferation because CD20 is required for making of the antibodies. So whenever the molecule is given, it is going to block formation of the antibodies, and hence it is going to be used for immunosuppression. If patient is symptomatic, you can give pilocarpine drops, or you can give the patient the eye drops of new tears or some methyl cellulose drops, which are going to keep the eyes moist. And you have to keep the patient on surveillance because this patient is of increased risk of lymphoma. We know that this is again an autoimmune condition. So that autoimmune condition, it is going to be because the patient is going to form antibodies, and these antibodies are formed because of B cells. So because of the hyperstimulation of these B cells, the patient might develop which is called as a chronic B cell lymphoma. It is called as CBCLL, chronic B cell lymphocytic leukemia or a lymphoma, and it is also called as a maltoma because it is going to form in the parotid. It is going to form maltoma. Sir, treatment क्या रहेगा? Treatment is chemotherapy, not excision. Any maltoma, we talked about it, any lymphoma anywhere in the body, any lymphoma, any maltoma, it is going to have a chemotherapy. There's no role of any surgery in any type of lymphoma. Sir, now we are going to talk about these last two disorders and then we are going to stop for the day. So ये चीजें सब लोग confuse होते हैं. So I can guarantee you that you might have got that confusion कि अरे what is the difference between a ranula, plunging ranula, mucocele and a retention cyst. तो simple करके बता रहा हूँ, एकदम easy for you to remember and for you to score marks. What is important is that if the problem is with the gland, then you are going to call it as a ranula. Ranula मतलब glandular pathology है. But if the problem is going to be with the duct, and उसके वजह से swelling हो रहा है, तो उसको मैं बोलूँगा mucocele or a retention cyst. So ranula is for the gland. If there is a ductal pathology, it is going to be a mucocele or a retention cyst. So क्या important है? So ranula में क्या होगा? Because of the trauma to the gland, there is going to be extravasation of the salivary gland fluids. So it is going to be a mucus of the salivary gland which is going to extravasate and going to form the cyst. So अगर मैं इधर देखूंगा तो ग्लैंड को ट्रॉमा होने के कारण एक सिस्ट बन गया, उसको मैंने बोला है रैन्यूला. बट दिस इज नॉट बिलो द व्हाट यू कैन से, दिस इज नॉट बिलो द मसल्स, इट इज यूजुअली बिलो द इन द फ्लोर ऑफ द माउथ. सो डायग्राम में थोड़ा सा गलत दिया है. सो दिस इज गोइंग टू बी अ म्यूकस एक्स्ट्रावजेशन सिस्ट फ्रॉम द ग्लैंड. सो एनी रैन्यूला प्रॉब्लम इज विद द ग्लैंड. अगर ये सिस्ट ऊपर और नीचे दोनों जगह से आया. So normally this myomucosal muscle which we saw in the submandibular salivary gland, this is going to restrict the cyst from coming downwards. So it is going to cause the cyst to only remain in the floor of the mouth. So if the ranula is going to come down from the myomucosal muscle, अगर वो अपना रास्ता नीचे ढूंढ के आएगा तो swelling will be above and also the below. It is called as plunging ranula. So nothing different. It is going to be a problem with the gland. Ranula is equal to problem with the gland, and the cyst is going to be formed because of it. Extravasation cyst, thick fluid-like content like lymphoma, you can say lymphatic collections, and excision of the submandibular gland is definitive. And अगर exercise नहीं करना है तो you can just open it up, marsupialize, the content is going to come out, and you can inject a sclerosant agent. So as good as you are making the gland die, so might as well remove the gland. Plunging ranula is when the ranula herniates to the myomucosal muscle, and CT is going to go for confirmation, and you can go for excision of the gland. So again, any problem with the gland, you are going to remove it. So ranula is the pathology of the gland. Now coming down to the mucocele. So whenever the minor salivary glands are going to have some retention because of the duct blockage, minor salivary glands में बोल रहा हूँ, तो it is called as a mucocele. But whenever a major salivary gland is going to have a ductal obstruction or ductal disruption, अगर duct में कुछ pathology आ गया, वो duct का सब content is going to come out and it is going to retain in the cavity which is called as a true cyst from the duct obstruction. So it is going to have an epithelial lining, क्योंकि वो धीरे धीरे बाहर आ रहा है. It is going to carry the epithelial lining along with it. It is going to be similar to the mucocele, and here also you are going to go for excision, क्योंकि मैंने already बोला कि duct को अगर trauma है more than 72 hours, you are going to go for excision of the gland. We have already seen any ductal pathology less than 72 hours go for primary repair, more than 72 hours go for excision. So retention cyst में problem is कि वो धीरे धीरे contents बढ़ के वो epithelial cavity में contents बन गए हैं. It is going to have a proper epithelial lining. Problem is with the duct, so there is no point in saving the gland. So you are going to go for straight away you are going to go for excision of the gland. So I hope it is clear that ranula is the glandular pathology and ductal pathology is because of mucocele and retention cyst. So ये दो diseases अगर तुम्हें याद है तो you can write any short note in any type of the exam. And always remember, for anybody the management is excision, but marsupialization with sclerosant can be given for glandular pathology, not for duct. तुम duct को अगर sclerose करोगे तो gland में और obstruction हो जाएगा, but gland को sclerose करोगे तो gland का function बंद हो जाएगा. So sclerotherapy अगर commonly अगर सोचोगे तो sclerosant कहाँ दोगे? gland के लिए, duct के लिए नहीं. वेरी मच इजी, वेरी मच 4 थिंग्स, वेरी मच स्कोरिंग फॉर द एग्जाम्स. ग्लैंड हम लोगों ने डायग्राम भी देखा है. सबलिंगुअल ग्लैंड के स्वेलिंग्स है मोस्ट कॉमनली सीन. आई होप इट इज क्रिस्टल क्लियर एंड दीज थिंग्स आर एज इट इज. सो वेरी मच इजी फॉर यू. लॉन्ग आंसर, शॉर्ट आंसर क्वेश्चंस क्लियर हो गए. इफ यू हैव एनी डाउट्स यू कैन पोस्ट मी एनी टाइम. टिल देन वी आर गोइंग टू मीट अगेन टुमारो वेयर वी आर गोइंग टू टॉक द मैलिग्नेंसीज ऑफ द salivary gland and then we are going to start with the next chapter. So thanks for attending the lecture. I hope you are happy with how the pattern is going off. If you have any doubts you can straight away ping me. Okay, till then chalo, take care, bye bye and good night.